And
I'm Jillian Mason.
this is Medicare for All, the podcast for everybody who needs health care. So, we have a really interesting topic this week, and it's a topic that is interesting because it potentially have a major impact on the Medicare program for seniors that we're trying to improve and expand to everyone in the country. But probably you have never, ever heard of it. I certainly hadn't. And we've quickly found out that even members of Congress don't even really know that this is happening. So we are talking about something called direct contracting in Medicare. Don't fall asleep when you hear the jargon. We're going to explain exactly what it means. And this is just the latest in kind of a long line of tactics trying to push Medicare towards privatization and being run a little bit more by for-profit companies. And today we are talking with a leader from Physicians for National Health Program about direct contracting entities. We're going to explain what they are, how they threaten beneficiaries of Medicare, and what we can do to stop this. So, Jillian, do you want to introduce our amazing guest?
I do. And our listeners should know that the reason that we have a guest here to explain this is because Ben and I are really confused about DCEs. So we needed to bring someone in who really knew what she was talking about. And so Dr. Claire Cohen, we're very honored to have her on the podcast. She's originally from Philly, now based in Pittsburgh. She's done amazing community activism work over the course of the years. In the 90s, she was part of the group that fought to get a civilian police review board in Pittsburgh. She's been involved in work on the school to prison pipeline, stopping it, obviously. She's a member of the Pittsburgh Green New Deal, and on the advisory board of the Pittsburgh Black Workers Center. And of course, she is also with Physicians for a National Health Program. And of course, she is also a doctor. So she's a child and adolescent psychiatrist. And we're so excited to have you. And this is a woman who can explain what DCEs are, why they're an issue of equity, and also why your adolescent kids aren't talking to you anymore.
Welcome to the program.
Thank you for that wonderful introduction.
I think adolescent psychiatrist might be about the right level to diagnose me as well, entering my mid 40s. So great. Maybe we'll tack on some extra counseling at the end of the program. So Dr. Cohen.
I get charged though.
Okay. Just as long as I'm not charged by a for-profit entity. So on this note, can you explain what the hell is a direct contracting entity? And how does a direct contracting program differ from like the traditional public Medicare that most people are eligible for once they reach 65?
Okay, so a direct contracting entity is a middleman between you and your insurance and your health care, not your insurance. It's a middle person who manages your care, who intercedes between your relationship with you and your doctor to decide what care you will or will not get and how much you will pay for it.
So they give us the denials and stuff.
Yes, that's basically what a direct contracting entity. And in this particular case, it's a middleman whose bottom line, whose main interest is how to make profit from that relationship. Not profit for you, profit for them. And you asked how it differs from traditional Medicare.
Yeah, exactly. Because I thought if you choose public Medicare, then basically the government is going to be the public Medicare system has a fee for service system. They reimburse doctors and hospitals, and we don't have these for-profit middlemen. So how does this happen?
So the way traditional Medicare worked from the beginning was that you pay taxes, and those of you if you ever look at your paycheck, there's
I do look at my paycheck very closely.
Yes. So you notice that you pay money to Social Security and you pay money to Medicare. Okay. Medicare is managed by a department under Health and Human Services called the Center for Medicare and Medicaid Services, CMS. So when you pay that money, it goes into a trust fund, which is managed by CMS. Okay. And in traditional Medicare, what happens? You go to the doctor, doctor, I need medicine, or I need a test, or I need you to examine me. That's called a service. The doctor provides that service, and then the doctor writes a bill and sends it to CMS. CMS pays the doctor out of that fund. It's pretty simple, pretty efficient, pretty easy. And what it means is that every dollar you put into that fund, 98 cents out of every dollar goes to direct patient care.
Right.
Only 2 cents is needed to administer that fund. So that's traditional Medicare. And that's extremely efficient, as you could see. But from its
People love it, right?
Yes, but from its beginning, there have been people who philosophically, ideologically, and in every way did not agree with having that kind of simple public fund in which all your money should go directly to helping you get health care if you're a senior or a person with certain chronic disabilities. Okay. So from the beginning, there's been an effort to try to insert middlemen who can make profit into the process. Okay. And for most of us, middlemen are insurance companies called health insurance companies. So
even though we know that they're not particularly devoted to health.
Yes, because you now have your bottom line is making profit. And because of the nature of healthcare, and we're not going to go into that here, because of the nature of healthcare, very commonly the bottom line of profit conflicts with the bottom line of providing care. That's for another show. Okay. So from the beginning, there was a push. In fact, that's the reason why we didn't have eye, dental, and hearing covered, because the idea was to placate those for-profit entities by letting them handle that part of Medicare. There's a long history. I'm not going to get into it, but this is how the two differ. So in 2003, President Bush, Part C of Medicare was not originally there. Originally, Medicare was just Part A and B, but Part C was invented in the late 80s, early 90s to be a place where private insurance companies would sit, okay? And they would be viewed as a part of Medicare.
So this is Medicare Advantage plans, right?
Yeah, so in 2003, and it's important to understand it because that's how DCEs came into being.
Right.
In 2003, Bush started the Medicare Advantage program, which was a takeoff from a program that Clinton started, which wasn't quite successful, called Medicare Choice. And in this idea, the government would actually act as if these insurance companies were an integral part, health insurance companies of Medicare, and it would do things to entice seniors to get into it, like allowing them to cover dental, eye, and vision, but not allowing traditional Medicare to. And it would do things to entice private entities into it, like saying, hey, you don't have to spend 98 cents of every dollar. We will give you a set fee every year, divided into monthly, called capitation. And as long as you spend at least 85 cents, no less than 85 cents out of that capitation for patient care, you can do what you want with the other 15%. So you can already see that Medicare Advantage was not going to be as economically efficient. Okay. Now, the insurance companies loved it, but of course they want more profit. So one of the things that they figured out how to do was they didn't give the exact amount of money, capitation, for each patient, because the insurance companies convinced CMS, well, some patients are sicker than others, so we might end up spending way more money, and we might end up spending 95%. So can you implement a program called risk scoring, where patients and I'm putting this in simple language. They didn't quite say, but this is the essence of what they said.
This
Can
is
you
the
implement a
simple
program
version.
called risk scoring, which means when we sign someone up, we score them for how much we think they're going to cost every year, and you give us a bigger capitation for someone like me, because I'm actually a senior who has controlled hypertension, controlled asthma, is just pre-diabetic, haven't flipped to diabetic yet. You you will give me, let's say, $10,000, but if I have, for every condition I have where I can show that a person is sicker, you'll up the amount of capitation you give me. So that's called upscoring. So if you can show that a senior has a lot of costly conditions, you might get $30,000 to $40,000 a year divided into 12. So you can see right away how they could make money. And by the way, one of the problems with Medicare Advantage is that, according to the Inspector General of the federal government, is that the 20 largest companies have fraudulently upcoded many of their beneficiaries, so they're getting way more money, capitation, than they need, which in order to increase their profit.
Right.
So,
So
bullshit standards that they've set
Yeah.
up, they're still
Okay.
doing it wrong.
Now, venture capitalists on Wall Street and private equity firms, the Medicare Advantage did so well. 40% of seniors signed up, but 60% insisted on staying with traditional Medicare. Wall Street looked and said, these insurance companies are doing really well here. We want some of that money.
Mm-hmm.
Okay? And how can we get the other 60%? Because we could really make a killing if we functioned like the Medicare Advantage programs do. So when the ACA was created, in the ACA was a provision to create a center in CMS called the Innovation Center to, quote, develop models that made Medicare even more efficient.
I feel like I can see where this is going to go.
Without compromising quality of health care. That just sat there for a while, but then along came Trump. And Trump said, well, we have an idea. And he got together a bunch of these Wall Street firms and said, this is a way we can privatize Medicare. Part of that thing also said that they did not have to go to Congress for vetting or questioning or authorization. They could just implement these models without even talking to Congress. And then if they felt that they worked, they could implement them as a program without ever talking to Congress. So Trump said, this is a great idea. I can privatize Medicare without ever talking to Congress. So he got together with some Wall Street equity people, and they developed this DCE program. And the idea would be that for-profit entities or companies, if you want to call them, could become the middlemen, just like health insurance companies could. But to make it even better for them, they decided you only had to spend 60 cents of every dollar for direct patient care.
All right.
So we go from 98 cents to 85 cents to 60 cents. Okay. Now, someone said, do you think seniors will buy this? No. So how are we going to get those 60% in? We have to sneak them in without their knowing. So that was the first model. They take the 10 big cities. It wasn't the 10 biggest, but 10 big cities. And interestingly enough, all cities that had a significant proportion of their population that was people of color. Houston, Philadelphia, Los Angeles, and I forget the rest of the cities, but all big cities with big, and without even telling people, without getting their permission. They called it aligning. We just put them in the DCEs. The DCE comes and you say, here's all the seniors in this metropolitan area. You got them.
So if I'm understanding you correctly, we've talked a lot about Medicare Advantage plenty in the past. So we know that Medicare has been partially privatized, and usually seniors, when they get on Medicare, they have a choice, allegedly a choice, even though we know there's lots of marketing and things like that to persuade people, or they receive lies and misinformation and all that other stuff. But you do nominally get a choice between the traditional public Medicare and the privatized for-profit Medicare plans. But what you're saying is that even the people who have chosen the public traditional Medicare can be just switched in to a for-profit company management system. Now, do these people even know it when it happens? How do
So
you learn about it?
with the original Trump model, with what's called the GEO model, no, you wouldn't know it until one day you had a heart attack, and all of a sudden you were told you couldn't get coverage for that.
Right.
Wow.
You had to get some expensive medicine, because remember, they're managing your care to
Right.
make sure they get more profit. So no, you wouldn't be told in advance, and you would just find out in a very bad way that you were in this. Okay. Now along came Biden. Biden did get rid of the GEO model, as it was called, but what they implemented was a second model that was sitting there on the table in CMS called the GloPro model. And in this model, what they do is we have direct contracting entities now functioning. So what they do is Medicare, every doctor in the United States, including myself, nowadays has a number. It's called an NPI number. And Medicare can use, and every time you write a prescription or diagnose or do some kind of procedure, you have to use your NPI number. And who looks at these numbers to see what you're doing? CMS. So they use this to track and see what doctors are doing, what every doctor's doing. Okay. So CMS would use this to find out who the patients were the doctors were seeing and who was seeing what seniors. That would be CMS's role. The direct contracting entities, their role was to develop these enticing programs to convince doctors to sign up with them, like Clover Health or Oak Street or Village MD. And there's advertisements you can see where they tell a doctor, if you sign up with us, because doctors in the United States are overburdened with all this authorization and billing and all this administrative stuff. They're the worst of all the doctors in the world, and doctors hate it. But they say, we'll set up this computer system and we'll do it all for you. We'll even diagnose and code for you. Okay?
Oh, my.
Yes. So we'll take care of it, okay, for you. So you sign up with us, and we might help you increase your income. So, but what happens is your patients are automatically, it's called aligned again. Your patients, your senior patients, will be automatically put in that DCE. Now, the way that they have it under the Biden administration is you will get a letter. The patient will get a letter. We have seen some of the letters. They're the type of letters you get like when you have a credit card or you have a loan and you look at the letter and your eyes cross because it's saying all this.
It goes immediately in the trash bin.
Jargonistic stuff. But it says you should sign it. And you sign it because you think bad things might happen. I don't understand what I'm signing, but I don't want bad things. And it says it'll be good for me. So you sign it, but you don't really understand it. So everybody knows what I'm talking. That kind of letter comes to you. Okay. So they can say that they told you and informed you and you signed it. Once you sign it, the only way you can get out of that DCE is to quit the doctor you're going to and try to find a doctor who's not in a DCE.
Oh, wow.
So even though they say you can get out of it, you really can't. And if you really liked your doctor, you're stuck because now you have to find someone who's not in the DCE. You don't know if you'll like that doctor. So that's
especially, I was just going to say, this is especially funny because, of course, people who are opponents of single payer are always saying, if you have single payer, you'll lose your doctor, right? And here we have a case where privatized medicine is forcing people to lose their doctors.
Yes. So therefore, and PNHP met with Liz Fowler. So, that was what they said. Well, you have choice. You can quit your doctor and find a doctor who's not in the DCE. Now, Wall Street hopes, and CMS, by the way, hopes to have every doctor signed up to this by 2030 and everybody in them. Right now, actually, only roughly 300 to 350,000 seniors are aligned, as they called it, in DC.
So the goal is really to take over all of traditional Medicare under this program. It's it's not really a pilot project. It's a take over the world project.
Well, it's a pilot project right now because only 300,000 are signed up. But yes, their goal is not to stop at the pilot, but to sign everybody up. And proponents of this are saying, we're going to have single payer. It's going to be called Medicare Advantage for all. And we're going to show that you can have a for-profit system that's better than a single payer system, than a public single payer system.
Speaking of profits, can you just talk a little bit more about how do these DCEs make money off of this whole deal, this whole scheme?
So they make money, first of all, because when they get, first of all, capitation, they get a bigger percentage that they're allowed to use for profit. They only have to use 60%. Now, it doesn't mean they will just use 60%, but they only have to use 60%, and they can skim off 40% off the top. And upcoding, it's clear if you look at the literature of these companies that are interested in it, they've watched Medicare, and they are real interested in this upcoding stuff. And with that upcoding, so I'll give you an example. I'll give myself. So these numbers I'm giving you are roughly real numbers, but they're not exactly real numbers. I kind of modified them to make them easier to understand. So I'm like most people my age. I have some healthcare problems. I have controlled hypertension. I'm on the borderline between diabetes and pre-diabetes, and I have controlled asthma. Okay. So if I were to sign up for a DCE, if I were to sign up for Medicare Advantage, CMS would give, let's say I did United Healthcare, they would give them $10,000 every year to take care of me. And as long as they spent $850 of that in patient care, they could keep the rest for themselves. Now, if I was aligned into a DCE, like let's say Village MD, they would get $10,000 for me, but they would, as long as they spent $6,000 on, they could keep the other $4,000 for themselves to do what they want. And obviously most of it would be profit. What they could do, and what the Medicare Advantage has done, and when you look at the literature, what DCEs would like to do is do this fraudulent upcoding. So they would say, oh, hypertension, we'll call it malignant hypertension, even though I don't have malignant hypertension. Asthma technically is a form of chronic obstructive pulmonary disease. So we'll just call it COPD. Although most people, when they're talking about COPD, they really mean things like emphysema. So, and we'll say she's diabetic because she's on the line. She's almost there. We'll just go ahead and call her diabetic. And and there's other things. I have some stresses in my life, so I'm a little down. They'll say I have major depressive disorder and I'm suicidal. So they will put those codes in. And because of the agreement with CMS where they can get more capitation for sicker people, they'll present me as sicker, and they will then be able to get, instead of $10,000 every year, $40,000 for me. Okay. Right. But this, although I'm not really at 6, and then they'll have 40% of 40,000, not 10,000. Okay. So that'll be for profit. Okay. So that's the main idea of how they do it. Other things that they do is the people who are really sick. Now, I don't know how they're going to do this once they get rid of Medicare, but right now, the way the Medicare Advantage companies, the people who are really sick, they try to kick them out and push them onto traditional Medicare.
Right.
In fact, it's become a real problem because some people, I understand, have actually died behind because it's not that easy to get back on traditional Medicare. Now, I don't know what they would do if there's no more traditional Medicare to kick people back onto, but they would definitely try to find ways not to provide care for really sick people because you don't make profit that way.
Yeah, that's exactly what I was going to ask you about next, actually, because I mean, the upcoding, obviously that's kind of stealing from the government. Essentially, you're stealing from taxpayers, bilking money. And it means that a lot of our money is just being wasted and thrown away into profits or administration. But for a patient who's been kind of aligned, I can't get over this verb. It's like a very Orwellian. You've been aligned. It's if you end up being aligned and switched into this for-profit management system, what is the impact for patient care? Does our care suffer if you get switched into one of these programs?
Yes. So this is the first and main way that you suffer, the doctor-patient relationship. So when you go to your doctor, you want to know that your doctor has your best health situation in interest, that your doctor is thinking about your health, how to keep you healthy, or if you're sick, to make you well as fast as possible, And that's what they're focused on. So right away, you have to worry. And I see this now. People are starting to worry about this with doctors, not just in Medicare. But you don't want to have to wonder if your doctor is recommending something because they want to make profit or somebody else wants to make profit, or they're recommending that you not do something, or they're recommending that you go someplace. You want to be able to trust when you go to your doctor that they are solely thinking about what's in your best interest healthcare. So the first thing it does is it damages the doctor-patient relationship because you don't know if you can trust your doctor. Okay. You don't know if their decisions are made in your best healthcare interest.
And this is because doctors are losing money the more care they give? Is that more or less how it works?
It's because doctors, it's worse.
Under this program?
Because under this program, one of the things they do, if you look at the DCs that are set up so far, is they offer doctors a cut of the profits. Okay. So, of course, they're not going to give them a big enough, that big a cut, but yes, they offer them.
But they make them complicit as much as they can.
Yeah, they make them complicit. I don't know what's happening to my picture there, but hopefully you can hear me.
Oh yeah, we can still hear you for sure.
Okay.
So I guess so I wanted to just talk some more a little bit about like how this is like a racial equity issue. It just seems like this is bound to have a really negative impact on communities of color. Like you already said, that they've started this plan in those cities. Can you just tell us a little bit more about that and what the impact could be?
Okay. So they never really got to start Trump's plan. That was the plan, but he didn't win the election. So they didn't get. The plan they've started is the one that's called the GloPro. And it's only been in existence about a year. So we don't have a lot of data. Most of our data comes from looking at how the Medicare Advantage programs function. But we're starting to get some data in. From what I've seen of some of the DCs that are already functioning, there's 53 right now, okay? And the majority of them are private equity and vintage capitalist firms. 6 of them are actually big healthcare insurance companies, and some of them are what's called ACOs. But so far, they're not making the big killing profit they had expected, but they've only been a year. Okay. But and they need to fine tune what they're going to do to get that profit. Okay. So I know that Anthem has decided it's not worth it and backed out of doing a DC. They were going to, I think it's Anthem. One of the big insurance companies has decided that to back off of it. But that there's others that are still pretty chafing at the bit to do this. So it would be nice if it turned out they weren't able to do as well as MAs and that they on their own decided these venture capitalists was not worth it. But we don't know that that's what's going to happen yet.
And in fact, it seems like it's not, right?
So looking at how it can affect people of color, obviously if Trump had his way, then it would be mainly people of color aligned. So there's a number of ways it could affect people of color. First of all, people of color, there's lots of studies showing that people of color they'll go to any doctor they can get, but many people would like to go to a doctor that's like them. And this is something I see in general, I treat the other end of the spectrum. So patients frequently want to see a particular doctor, but they can't. Because that doctor is not aligned with them. So, okay. So that's one of the situations. The other is, and that's your PCP. But even if, let's say, you need to be referred out to see a specialist, which they try not to get referred out. Yeah. The other is that oftentimes people of color, when they first get into Medicare, because of all the other inequities in the systems, in the whole general system, come in sicker and with more problems, more complicated problems. So they're at bigger risk of being denied, not authorized,
Mhm.
Or
care,
upcoded, right?
or yes, and then upcoded. Okay.
Yeah.
So, so, but then if you need to be upcoded, that's one thing. But
Mhm.
if they're denying you care and then fraudulently upcoding you, in fact, they might like to have more people of color, more black people, because hypertension is disproportionate in the black population. Okay.
Mm,
So you have more black people, you can do more upcoding to show that they have out of controlled hypertension. So
yeah.
it's one of the problems is it's not really addressing the issues of healthcare and inequities. It's really
Yeah.
just a farce to find a way to make more profit off the back of people of color. If that makes sense to you.
So, yeah, that totally makes a lot of sense. Yeah. Unfortunately, terrible, evil capitalist sense. Um, but yeah, so, all right. So, we obviously have to tell these big companies to go align themselves, right? And so, PNHP, the Physicians for a National Health Program, have been doing a really cool campaign fighting back against these DCEs. And I know you've been a leader in the campaign, Dr. Cohen. Do you think you could just tell us a little bit more about
Yeah.
that, and what have y'all
Okay.
been doing to fight back?
So we've done several things. First of all, we started a petition campaign back. It started around October. It really got going in November, and so far we have approximately 11,000 signatures. We have this posted everywhere. You can look everywhere. It's on Facebook. It's on Twitter. People are just passing it out. You can go on. You can go online. PHP. You can go on their website, and it pops up right there. And we've been encouraging people to sign the petition. There's now 3 petitions. There's us. There's Public Citizen, and I noticed the other day that Social Security Works has a petition. I don't know how many signatures they have on theirs, but we have 11,000 so far, approximately. And we're going to keep collecting at least through the end of February. So I would encourage people. You can just Google Physicians for National Health Program, and go to our website, and they'll pop up right away, and just click it and sign. So that's one thing. Another thing that we've done is we've worked hand in hand with Jayapal's office. First of all, let me tell you, there were 4 members of Congress who, even before we got, in fact, that's part of how we became aware of this, who noticed that this was going on way back shortly after Biden got in office, and wrote Secretary Becerra asking him to stop the program and expressing concerns.
Yeah.
Those Jayapal wasn't among them, but she's now put out a letter too, and 54 Congress people signed it, asking them to stop the program. But there's more than 54 Congress people. There's
A few more. Yeah.
Yeah. So what we're asking people to do is call their Congress people. It's too late to sign that letter, but calling them and asking them to call and put pressure on Health and Human Services. And you see the number right on this. Well, that's the number for Health and Human Services. So you can call Secretary Becerra, is his name, directly at that 202-205-5445 number. You can call directly and say, I don't want this DCE program. We're asking you to stop it. Just end it. Okay. And if you're on traditional Medicare and have elected to be on there, you can say, I want my
Right.
Medicare.
Yeah.
And that's what I've done. I've actually said, I want my traditional Medicare. I do not want for-profit middlemen in my care. That's what I said.
Yeah.
Okay. So we're asking people to flood the lines, flood Becerra's line. And then there's a phone number, the one under blue there. That's the Capitol switchboard. Don't be intimidated. Call that switchboard. It's real easy. Give your name and your zip code. They'll give you the phone numbers of your House of Representative members and your senators. And you call them and you say this, and you say to them, we want you to call Secretary Becerra, tell them to stop the program, and we want you to hold hearings on this whole situation, okay, on how we can stop it. And not only how we can stop the DCEs, but how can we implement a trial of Medicare for all, of single payer health care, okay? That would cover everybody without the profit. So that's the thing. And then there's one more thing, or actually two more things. We have an organizational letter that's going around for organizations to sign.
Which we have signed. Healthcare Now is all signed on.
Yes, and a lot of organizations are signing on. And then lastly, we're developing this interesting program we're still developing called Medicare Protectors, in which we're going to do some kind of thing to acknowledge and reward Congress people that,
I see. Yeah.
That and we're still developing that. We will want people to really press their Congress people to become Medicare protectors. Protect Medicare as a public good, non-for-profit thing that services everyone. Expand it to the cradle and cover everything.
Right. Don't be an aligner. Be a protector.
Yes. I like it because it sounds like a superheroes, you know?
Exactly.
Like the Avengers, but with Medicare for all.
Protectors of the universe.
Yes.
Yeah.
So we're still in the process of fine-tuning that program, but that's the last.
Okay. Well, I really appreciate the organizing. Yeah.
And we have a question from Daniel F. on YouTube about how we can generate interest in this movement. And I think one of the ways that ordinary folks can generate interest in this movement is by talking about it, right? This is all, this is the scariest part about this stuff is that it's happening behind closed doors. Most people don't know about it. So please share this link so that other folks can hear what Dr. Cohen has to say, hear the explanation, and bring it up with your friends and your family around the dinner table, if you're not in COVID isolation and capable of eating dinner together. Otherwise, over the family Zoom.
The Zoom table.
Yeah, I find that when you talk with regular folk, when you talk with your family and friends, when you talk about that 60% versus 85% versus 90%, that really hits home with people. So when you talk to people, that's one thing to bring up, because people say, "Wow, you mean you're going from 98 cents to 60?" The other thing that really hits home to people is when you talk about how you can't get out of it without quitting your doctor. That's another thing. People don't want to have to be forced to quit a doctor they like to get out of a program they don't like.
Yeah, I think there's three things about this program that really terrify me. One is that although within the healthcare system at large has tiers of sort of coverage, you can have, a Medicaid system, you can have private insurance, you can have Medicare, you can have all sorts of different levels of coverage, and it's a baked in and equitable system. Medicare was created to be an equitable system for seniors, to not have tiers of coverage within it. Now, Medicare Advantage was the first kind of crack in that, in some of the predecessors to Medicare Advantage that you talked about, where suddenly we do have these big tiers within Medicare. But these direct contracting entities are like another third tier where you could get, a letter where you get tricked into joining it, and suddenly you have worse care or are more likely to be denied care than someone else in a traditional Medicare program, which you probably signed up for in the first place. And then, just like you were saying, also traditional Medicare generally doesn't have huge limited networks. Most doctors and hospitals accept traditional Medicare, so it's not like you get trapped in or out. But suddenly, if you end up in one of these DCEs and your preferred doctor is not aligned properly, I just can't get over this word, then suddenly you do have limited network. And then the third thing that really terrifies me about this is that Congress was basically bypassed in this. There's this massive change to Medicare, which is created by law. It's in law. And they use like a loophole in the Affordable Care Act, which is intended to expand coverage for the country, and are now using it to basically change one of our most important social programs in the country behind closed doors, without anyone knowing about it and without Congress getting a say in it. So I think members of Congress should fight this, no matter what they think about it, just for the right to legislate any major changes to Medicare.
In fact, the 54 that signed, that was the most appealing thing to them. they're
Mhm.
making this big change and we have no say in it. Yes, that was that.
Yeah.
Yeah.
Crazy.
Yeah.
Well, thank you so much for joining us and kind of educating us about this. I learned a lot here. I'd heard a little bit about how it was working, but I really didn't know all the details. And this is literally my job. So if I don't know what's happening here, I'm sure most people have absolutely no idea. And this is really eye-opening and a little bit scary. So we will be joining with PNHP and fighting back against this, and I hope all our listeners do as well. And I just wanted to, in addition to thanking you, I wanted to thank our podcast team. So I want to thank Angelique, our podcast manager. I want to thank Sophia, who is our writer and researcher for this episode. And I want to thank Christian, who is our audio editor. Without them, we would be in a lot of trouble. And Jerry Katz, who's our show notes writer. So thank you all so much, and we will be back in a couple of weeks. Take care.
All right.
Stay safe and stay dangerous, folks.
Yes, bye, everyone.
And keep fighting for Medicare for all.